Good afternoon, everybody. Welcome to this oral session, this exciting and diverse session where we will have abstract selected in medical oncology, pathology, biology, about focal treatment. Before proceeding with the session, I would like just to tell you that there has been a problem in the program. And the keynote presentation of Professor Mejean will be at 4:30 p.m. and not at 5 p.m. So 4:30 p.m. Please be here with us. Our first speaker is Dr. Atkins. Dr. Atkins.
I'm starting with 1 minute and 15 of extra time, or maybe that's all I have left. But I'm going to talk about cross-trial propensity score weighted analysis comparing Nivo/Ipi in the 214 trial versus nivolumab monotherapy in the HCRN trial that I talked to you about this morning. So our learning objectives are to gain some knowledge on the contribution of ipilimumab to the efficacy of Nivo/Ipi in the IMDC intermediate and poor risk patients who were treatment naive and using this cross-trial propensity score weighted analysis, and then also to gain some knowledge on the relative efficacy of Nivo plus Ipi versus Nivo monotherapy in the IMDC any risk patients using the same analysis between these two trials. So as background, based on the results from Checkmate 214, Nivo/Ipi is an established treatment for intermediate and poor risk patients with treatment-naive metastatic kidney cancer. And the recent results, some of which I talked to you about this morning of Part A of the single-arm HCRN trial, indicate that Nivo monotherapy has activity in this patient population. And one could make indirect comparisons between those two studies, but they're always fraught with some issues. And in order to have, in the absence of head-to-head comparisons, which may be coming soon, the best way to potentially do this comparison is to have a cross-trial propensity score weighted analysis comparing the efficacy of the combination versus Nivo monotherapy in these patient populations looking at these two trials. So here are the two trials. Checkmate 214 looked at Nivo/Ipi versus sunitinib, and the HCRN trial that I talked to you previously was a single-arm trial looking at, in the first part, Nivo monotherapy, and the trial design is shown here in abbreviated fashion. For propensity score weighting, the key to this successful cross-trial comparisons is to try to mimic the randomization by identifying clinically relevant baseline characteristics and ensuring that patients in these different trials have similar values to prevent some co-founding due to imbalance. And one accepted method for doing this is via the generation of individual propensity scores for each patient, representing their probability of treatment assignment conditional on the observed baseline covariates using logistic regression. And all clinically relevant baseline characteristics that were common between 214 and 260 were included as baseline covariates, and patients were excluded if data were missing from more than one of the selected baseline characteristics. So because overall response rate and PFS were reported in both of those trials, we chose those to look at for our efficacy outcomes of interest, and these efficacy outcomes were compared between the two trials for the intermediate and poor risk population and the whole population of the trials. And data is going to be represented as either unweighted, which is the raw data before the propensity score weighting or as PS weighted in the following tables, which is after applying this propensity score weighting. And then looking at everybody, the any risk population, looking at the patients enrolled in both the unweighted, in the unweighted categories, you can see in the very sort of light blue, unfortunately not easily seen, shading here that there was some imbalance in terms of age, ECOG performance status, corrected calcium, and tumor size, which was corrected as shown in the PS weighted group by this propensity score analysis. And in looking at overall response rates, we see that the rates were numerically higher for both the unweighted and the propensity score weighted populations in this particular any risk analysis. And for PFS, we see that there was not a statistically significant difference in PFS in the unweighted population, but in the PS weighted population, you can see that that difference in PFS now becomes statistically significant. Looking at the baseline characteristics for just the intermediate and poor risk population, we can also see that there was some imbalance in the unweighted samples as shown in the light blue for the same characteristics, age, performance status, corrected calcium, and tumor size. And you can see how they were corrected with the propensity score analysis. And looking at the overall response rate comparisons, you can see that between the trials, Nivo-IPI showed a numeric improvement that was clinically relevant between in overall response rate compared to Nivo monotherapy in both the unweighted and the PS weighted samples. And in looking at the PFS comparisons between the two studies, you can see a statistically significant difference in the unweighted and the propensity score weighted favoring Nivo-IPI compared to Nivo. So I'm going to summarize ahead of time that this exploratory cross-trial propensity score weighted analysis suggests that Nivo-IPI provides efficacy benefits over Nivo monotherapy in both the any risk or whole population and particularly in the intermediate and poor risk populations in these treatment-naive patients. In the unweighted analysis, overall response rate and PFS benefits of Nivo-IPI over Nivo were observed only in the IMDC intermediate and poor risk population, and after applying propensity weights and adjusting for these confounding effects, there was less bias in the estimated treatment benefits of Nivo-IPI over Nivo, and the overall response rates and PFS were longer for Nivo-IPI in both IMDC groups, but particularly in the IMDC intermediate and poor risk population. So this is the data we have at the moment. We have to wait for the phase 3B Checkmate 8Y8 trial, which Dr. Albages is leading, for the direct randomized prospective comparison of Nivo-IPI and Nivo, unfortunately limited to just the intermediate and poor risk populations of treatment-naive patients with kidney cancer. And so I'm going to close by recognizing all the co-authors on this particular abstract, as well as the people who were involved in the two clinical trials, and also acknowledge the support from BMS for pulling this data together, and to the patients and families for their willingness to participate in these trials. Thank you very much.
Thank you.
Thank you so much for an excellent talk. I just want to remind you that it's the top 5 abstracts who are presented here, and the organizing committee want to thank all the authors for submitting their studies to this meeting. It has been a hard work for the authors and also the co-workers. So, and there will be some mic for the questions. There is mic put up in the back of the room as well. Abstract number 2 is going to be presented by B. Mercier. It's health-related quality of life, measures in renal cell carcinoma. Please.
Thank you for the lovely introduction. Hello, everyone. So today I'll be presenting our study on health-related quality of life in RCC. Here is our list of authors, and I have no disclosures to make. So to give a little bit of background on what health-related quality of life actually is, we operate on the definition of the perception of one's own physical and or mental health and how that perception impacts a person's overall quality of life, excuse me. And we found that there's sort of a lack of consensus in our little corner of the scientific community here in that there isn't really a standard health-related quality of life measurement present in all studies. And with the development of new treatments and therapies for RCC, these assessments that have already been developed may actually be outdated. So our study actually expands upon a previous study conducted last year evaluating specifically metastatic RCC patients using just the FACT Kidney Cancer Symptom Index, or the FKSI19. And our results can be found below there. And so our goal for this study is to better understand patient experience and perception of current metrics of health-related quality of life in patients with both localized and metastatic RCC. And we also like to characterize additional areas of inquiry that patients may wish to see in the future. So to begin with our study, our eligibility simply was that the patient needed a formal diagnosis of RCC. And when a patient agreed to partake in our study, we asked that they assess each individual item of the FKSI19, ERTC, QOQ-C30, and EQ5D. And so patients would rate each of these items as relevant or not relevant. Relevant in this case, meaning that a patient felt that this really pertained and had a bearing on their overall quality of life throughout their RCC experience, and not relevant essentially meant the opposite, that it had no bearing on their experience. And so after that, we asked that patients comparatively rank each assessment, and then following that, we would ask that patients suggest additional items of inquiry for future assessments. Afterwards, when we analyzed the data, we felt that the threshold of 66% or more of response of relevant or not relevant were determined to be meaningfully relevant or not relevant. And so this data was actually independently reviewed, analyzed, and compiled into descriptive statistics by 2 independent reviewers, independent of the accrual process. And so our patient characteristics. So here at City of Hope, we enrolled 73.3% of our 116 patient cohort. At the Cancer Center of Brasilia, we accrued 18.1%, and at Emory University, we accrued 8.6%. And so the median age of our cohort was 64, with 69.8% of them being male, and 88.8% of them having clear cell histology. And so 83.6% of them were metastatic, and approximately 75% of these patients were on active treatment using either immunotherapy, targeted therapy, or a combination of the two, and 32.8% of them were on their first line of treatment. For the FKSI19, we found that these following items were relevant. Note that fatigue and worry are making a return from our previous results last year from our previous study of the FKSI19. And we found these following items to be not particularly relevant. Note that nausea, blood in the urine, cough, and fevers all were found to be not relevant as well. For the ERTC QOQ-C30, we found that just these 3 items right here were relevant from the 30 total: overall quality of life, overall health, and feeling of tiredness. And we found that these items actually were found to be not particularly relevant to patient experience. For the EQ5D, we actually found that none of these items were particularly relevant according to patients. None of them made our threshold of 66% or higher. However, we will note that anxiety, depression, and pain both came close but didn't quite meet the threshold. And self-care actually was found to be not particularly relevant to many of our patients. Patients comparatively assessed our assessments here, with the majority of them finding that the IKCSEU23 and the IKCSEU23 were found to be the most relevant, with 36% and 35% of patients respectively, and 26% of patients found the EQ5D to be most relevant, and just 4% found no preference between all three of them. In terms of patient suggestions, the majority of them, 65% of which, felt that there were nothing to add. One possible explanation for this may be the fact that many patients felt that there were too many questions of these assessments. Some felt that there was really nothing more to add. However, of the patients that did feel that additional areas of inquiry were necessary, they felt that treatment-related symptoms and emotional symptoms were actually the top two in terms of what they wished to see, in addition to a few others that are listed. And so our study was not without its limitations, of course. We had a limited cohort of localized RCC patients, unfortunately. However, this is something we're working to rectify. Our study is currently ongoing in terms of its accrual. We recently opened up a new accrual center at the Barts Cancer Center down in London, and we're working to increase accrual at the Cancer Center of Brasilia, both focusing on accruing localized RCC patients. So unfortunately, because of that lack of localized patients, we weren't able to provide a comparison of localized versus metastatic RCC. And treatment for patients at the time of enrollment actually varied quite widely. Some, for example, were on just active surveillance for a number of years after undergoing localized therapy, while others had just began systemic therapy. And of course, the majority of our patients were accrued from City of Hope, representing sort of homogeneity in our cohort that we are, again, working to overcome. So in conclusion, we believe that updated assessments for health-related quality of life evaluation are warranted. And we will be developing a new questionnaire using these findings from this study and our previous study alongside our expert team. And we will be hopefully creating a new questionnaire that we will then validate in future clinical trials. I'd like to thank the KCA for giving me the opportunity to speak to you all today. I'd like to thank Chris Bergerow, our principal investigator for the study, and I would like to thank every member of our steering committee, as well as all the patients who were willing to give us their time to partake in this study. We could not have done it without them. Thank you.
Thank you. Excellent talk. Our next speaker is Dr. Teresa Juncker. She's from the Research and Innovation Unit of Radiology in Denmark.
Thank you very much for the presentation, and thank you very much for the opportunity to present this work that I will be presenting on behalf of our Danish research team that you can see named here. This is our poster. You can find it in the poster walk. As you all know, the incidence of incidental findings of small renal cell carcinoma is increasing. And partial nephrectomy is the gold standard in curative treatment, but new alternative treatment options like percutaneous cryoablation has emerged, especially relevant for the elderly patients and the comorbid patients. In this study, we aim to assess the patient's experiences on the course of treatment following partial nephrectomy or percutaneous cryoablation of clinical T1 renal cell carcinoma. It was a cross-sectional study, and we included patients treated with either partial nephrectomy or percutaneous cryoablation between June 2019 and February 2021. They all had clinical T1 RCC, and we included both robot-assisted procedures and open procedures. We recruited the patients from 2 university hospitals in Denmark, the University Hospital of Zealand and the Odense University Hospital, covering over 1/3 of the Danish population. The treatment decision was based on a multidisciplinary team conference with the participation of pathologists, radiologists, oncologists, and urologists. And then finally, the final treatment decision were made between the physician, the urologist in this case, and the patient. We had the exclusion criteria that if the patient didn't sufficiently understand Danish, or had any dementia, or had metastatic disease, or any conversion to radical nephrectomy or salvage procedures. To evaluate the patient's experience on their course of treatment, we used the rehabilitation questionnaire for renal cancer. It was originally developed by a Danish group. It consists of 7 questions, and it was redesigned for renal cell carcinoma patients and locally validated by Nissan et al., or Asavi et al., sorry, waving for me down there. The RQ-RC was distributed together with 2 other questionnaires as a part of a study regarding quality of life after nephron-sparing treatment of renal cell carcinoma. Therefore, this questionnaire underwent some preliminary testing with some experts and laymen, and also 10 cognitive interviews with patients from the study population. The questionnaire was either electronically or manually distributed according to the patient's preferences, and it was sent to the patients 3 months after the treatment. In total, 163 patients out of 175 patients responded to the questionnaire, generating a response rate of 93%. Hereof, 76% or 76 patients had the partial nephrectomy, and 87 had the percutaneous cryoablation. The patients that received the percutaneous cryoablation, they were significantly older, they had a higher Charlton comorbidity score, and they were treated for significantly smaller tumors compared to the partial nephrectomy group. We found that most of the patients reported being satisfied or fairly satisfied with their treatment course. It was 91% versus 87% treated with partial nephrectomy and cryoablation respectively. We found that patients treated with the cryoablation were less likely to think of themselves as a cancer patient than the partial nephrectomy group, but they were more likely to think that they have had a complicated course of treatment. We also found some significant differences in how patients were thinking about having, or how often they were thinking about having had cancer between the groups. But we found no other significant differences between the 2 treatment groups. So in conclusion, patients treated with nephron-sparing treatments at our institutions with either partial nephrectomy or percutaneous cryoablation for the small renal cell carcinomas report being equally and highly satisfied with the course of treatment. So I would like to send a special thanks to all the participating patients and their relatives for participating in this study, and to all my wonderful clinical colleagues who had helped me localize these patients, and to the co-authors of this abstract. Thank you.
Great presentation. Thank you so much, Teresa. The next presentation is abstract 4. It's eosinophilic solid and cystic renal cell carcinoma, a rare new intensity, presented by Virginia Facala.
I'm a pathologist at the European Georges Pompidou Hospital in Paris and working with Arnaud Méjean and Stéphane Houdard. And I would like to, at first to thank the scientific committee to give me the opportunity to present our cohort of eosinophilic solid and cystic carcinoma. The main objective of our study was to describe the clinical and genetic feature of cases of eosinophilic solid and cystic RCC diagnosed in our department of pathology. And the two other objectives were to present diagnostic criteria of this rare entity and management strategy for patients with localized or metastatic disease. Briefly, in introduction, eosinophilic solid and cystic RCC is a new renal cell carcinoma introduced in the last WHO classification, 6 years after the first description of a cohort of 16 cases in 2016 in sporadic case, which was supposed to be the sporadic counterpart of previous case described in tuberous sclerosis complex 2 years before. With around 100 cases described until now, ESC-RCC appears to be mostly sporadic and could occur in the hereditary context of tuberous sclerosis complex. There is a female predominance with age range from 7 to 75 years, and tumors are mostly localized PT1 with variable size tumor. There is a low metastatic potential with only 6 cases described until now and few locally advanced tumor. Interestingly, as you see this morning, genetic analysis demonstrate recurrent TSC1 or TSC2 mutation, which seems to be a driver in this tumor, often associated with B allelic loss of TSC1 or 2 that lead to activation of mammalian target of rapamycin pathway that could represent a target therapy for metastatic patient. Criteria for diagnosis of ESC-RCC are based on a combination of morphological feature and a specific immunophenotype profile, and molecular analysis by next-generation sequencing could help, but are rarely performed in routine diagnosis. So very, very easy to remember. ESC-RCC have a solid and cystic architecture. Proliferation consists of polygonal neoplastic cells with voluminous eosinophilic cytoplasm, harboring frequent course basophilic cytoplasm sleeping on vacuolization, and the hallmark of the immunoprofile of this tumor is expression of cytokeratin 20 in almost all tumors, which can be either patchy with few cells to diffuse pattern. And more recently, aberrant expression of myelin A and cathepsin K, which are melanocytic markers, have been reported. Other biomarkers help to differentiate this tumor from other eosinophilic solid and eosinophilic tumors. So in our cohort, diagnosis for ESC-RCC have been performed since 2016 on 9 samples from 8 patients. Sample includes 3 renal biopsy, 4 partial nephrectomy, 1 radical nephrectomy, and the last one, 1 supraclavicular lymph node biopsy performed for a patient with synchronous metastatic, initially unclassified RCC, including a specific French genomic program to identify target therapy 2 years after 1 line of pembroaxitinib and the second line of cabozantinib. So clinical pathological data are summarized in this table, and we also find a female predominance with only 2 male, median age 38 from 90 to 61. We also have PT1 stage, and we didn't find any other metastatic case in 6 cases with median follow-up of 26 months. Our genetic analyses were performed on localized tumor by next-generation sequencing with a panel using 29 genes dedicated to renal oncogenesis. And we identified in 5 of 6 tumors alteration on either TSC2 or TSC1. 3 of them were germline mutation, including 1 unknown TSC. 2 had TSC known disease, and 2 were sporadic associated with B allelic loss of TSC2. For the metastatic tumor, our results were very surprising. By whole exome sequencing, we do not identify any germline or somatic TSC1 alteration, but tumor harbor homozygous deletion of CDKN2A and TFB amplification that was subsequently confirmed by FISH using a break-apart probe with TFB. This result led to reclassify this tumor in TFB amplified RCC. So I will focus my brief discussion on diagnostic pitfall and management of ERC-RCC. As you see, our cases meet morphological and immunohistochemical criteria. In localized tumor, we identify, as expected, high rate of TSC alteration. All cases were managed by surgery, and as you know, as you see, oncogenetic consultation allow us to identify a new TSC patient. However, our cases, our metastatic case, had to be reclassified after the genetic analysis as TFB amplifier RCC. And very interestingly and recently, last year, AMOC published a recent study that revealed overlap feature between ERC-RCC and TFB alter RCC that include a TFB amplified RCC, which is known to have a worse prognostic. So both entities can share melanase and cathepsin K and even cytokeratin 20 positivity, even if TSC1 or 2 are more frequent in ERC-RCC, it could be encountered also in TFB amplified RCC or TFB with translocation. And in fact, FISH TFB is the best genetic analysis to confirm or infirm the diagnostic of ERC-RCC. Following my bad experience with this metastatic case, I review, and the diagnostic before, I review all other cases published with metastatic ERC-RCC report in 5 studies with 1 more locally advanced cases, and only 1 eliminate TFB amplified RCC by comparative genomic hybridization. No information on TFB alteration was available in 6 other patients, and only 2 had molecular analysis by next-generation sequencing. On the 2, only 1 had TSC2 alteration. It was a young teenager who responds to mTOR inhibitor treatment. So given the molecular feature of ERC-RCC, in perspective, obviously, mTOR inhibitor therapy should be indicated in first line for ERC-RCC. So for conclusion, 3 take-home message. What does this mean for my practice on Monday? So I'm a pathologist. So I would like to perform systematically extensive immunohistochemistry, including TFS3 melana HMB constant, and of course, also FISH TFB or 3 to confirm the diagnosis of ERC-RCC. And what does this mean for the future of care? Refer patient for oncogenetic consultation to look for polysymptomatic tuberous sclerosis, and also perform systematically somatic and next-generation sequencing for metastatic ERC-RCC to adopt systemic therapy against mTOR pathway and in case of identification of TSC1 and 2 mutation. Thank you for your attention.
Thank you so much, Dr. Verkar, for this excellent presentation. It recalls us the presentation of Dr. Elizabeth Hensky this morning on the proximity between TSC1 mutated tumor and TFE3, TFEB altered tumor. So thank you so much. The last talk is for Dr. Ajuria. Dr. Ajuria Karin. So she's assistant professor in Belgium, and she has done the work while she was fellow at Gustavus Institute.
Well, first of all, I would like to thank the scientific committee for accepting our work as oral presentation, and thanks for the Merit Award. So today I'm going to present our abstract baseline circulating soluble factors as predictors of benefit from nivolumab in metastatic RCC, additional multivariate analysis of the pooled nivo-ren translational population. Okay. Well, I didn't have any disclosures to declare. So immune checkpoint inhibitor-based combination therapy is the standard of care for first-line metastatic RCC. And we know that, however, there is still a significant percentage of patients that will be refractory to checkpoint inhibitors. To date, there is still no validated biomarker of response to checkpoint inhibitors to help us guide treatment selection in first-line setting. The nivo-ren translational program quantified circulating soluble factors at baseline and correlated them with clinical outcomes in pretreated advanced RCC patients receiving nivolumab. The preliminary analyses that were presented at ASCO last year, they showed us that there was a significant association between high baseline levels of circulating interleukin-6 and interleukin-8 inflammatory cytokines and worse overall survival and worse progression-free survival. We also observed that there was a significant association between high baseline levels of vascular endothelial growth factor, circulating vascular endothelial growth factor, soluble factor, and also of other B-cell related soluble factors like BAF, and also the B-cell attracting cytokine, CXCL13, with worse overall survival. We didn't find any associations with objective response rate. The objective of the analysis presented today is to confirm and evaluate if there is an association between baseline circulating soluble factors and worse overall survival or PFS in the overall nivo-ren translational population. For this, we conducted the study as part of the translational program of the nivo-ren study, a single-arm phase 2 trial with nivolumab in a real-world context population. And we collected peripheral blood samples from 617 patients out of the 719 patients included in the trial. We quantified a panel of 8 soluble factors at baseline from plasma samples of 353 patients using the MSD immunoassay. There you can see on the slide the different 8 soluble factors, inflammatory cytokines such as interleukin-6, interleukin-8, VEGF as an angiogenic but also inflammatory factor, VCAM, interleukin-7, the T-cell involved in T-cell activation also for 1BB, and also other B-cell related soluble factors such as the B-cell attracting cytokine but also the B-cell activating factor. The cutoff used for the analysis were those previously identified in the training and validation cohorts already presented last year at ASCO annual meeting and ASCO GU. For the multivariate analysis, we included clinically relevant variables, but also all the soluble factors that were then suppressed step by step according to statistical significance. On the slide, you can see the fresh results, the descriptive analysis with the baseline characteristics on the left, that they are in line with those previously reported for the nivo-ren trial. And then on the right, yes, left, right. On the right, you can find the main clinical outcomes with a median follow-up of 53 months. You can find a median PFS of 3 months and a median overall survival of 24 months with an objective response rate of 20%. That was the population we analyzed for this study. So here you have the results, and as you can see, we confirmed a significant association between high baseline circulating levels of interleukin-6 and worse overall survival and worse PFS. We also confirmed a significant association between high baseline levels of circulating interleukin-8 and worse OS and PFS. We also confirmed the significant association that we had previously observed between high baseline levels of circulating VEGF and worse overall survival, and the negative trend that we had previously observed between high baseline levels of VEGF and a worse PFS became statistically significant. Here you have the B-cell-related soluble factors. We confirmed the association with worse overall survival, but we didn't find any significant association with PFS. And then other soluble factors such as VCAM and the interleukin-7 that for which we had observed a negative trend but not significant previously, they became statistically significant on this analysis. No significant associations with PFS were observed for these two soluble factors, and for FOAM-BB, no significant associations with OS or PFS were observed. Here you have the multivariate analysis, and on multivariate analysis, the only 3 cytokines that remained significantly associated with overall survival were interleukin-6 and interleukin-8, both inflammatory cytokines related with myeloid inflammation, and then the B-cell-related soluble factor BAF. Interestingly, the presence of brain metastasis and interleukin-6 had the greatest impact on survival. Regarding PFS, the only cytokines that remained significantly associated were interleukin-8 and all the other B-cell-related soluble factor, CXCL13, the B-cell attracting factor. Again, the presence of brain metastasis, together with interleukin-8 in this case, had the greatest impact on PFS. So in conclusion, our results confirm the prognostic role of interleukin-6, 8, and BAF as potential prognostic markers beyond other standard clinical prognostic factors in advanced RCC treated with nivolumab. And our results suggest also a potential predictive role for interleukin-8 that needs to be confirmed. Pre-specified analysis of these soluble factors on randomized clinical trials could help us confirm the prognostic role, but also explore and clarify if there is a predictive role for these cytokines, especially interleukin-8 and maybe BAF. So this is a small slide, but thank you everyone, and special thanks to the RCC research group at Gustavo C, and led by Professor Alvilles. Also to Professor Chaput, she is not here, but she is the head of the Laboratory of Immunomonitoring at Gustavo C, with whom we collaborate a lot. The rest of the RCC research group, that a lot of them, they are here, and thanks for all my time there. And thanks everyone and the families and patients. Thank you.
Thank you all for your presentation. It was wonderful. Thank you all for your participation. We'll now be moving into Q&A. Please submit your question if you have any. So, any questions? Professor Udar?
Very nice presentation. For the last speaker, yes, here.
Sorry.
Yes, did you look at the C-reactive protein based on the IL-6? Did you look at the relationship between the CRP and the IL-6?
We didn't have the CRP.
Okay.
Yeah, but that's a good question.
Okay.
Yeah, thank you.
Just to continue that, did all the patients have a CT of their brain for brain metastasis?
Sorry?
Did all the patients have a CT scan of their brain for CT for brain metastasis?
Yes. Yes.
Okay. I would like to ask you a question on the role of some chemokines, so CXCL13. So usually it has been associated with improved response to IO. So here when we see your slide, we see, like in your slide, you're showing that when the level is high, is associated with good response, with bad response, but in the multivariate analysis, it was associated with improved response. Can you comment on this?
No, I don't think so.
Oh, is it good or bad?
Bad.
In any way?
But it was bad. Actually, it's interesting because it's true that in the literature we can see that, I think it was also in bladder cancer and in other cancers, it's associated with a good response, but I've also seen that it was at the tumor level, the expression at tumor level. So I don't know if there is a difference between circulating and tumor level. In our series, actually, we also, in a different paper, we evaluated the correlation between the TLS, for example, and the CXCL13, the B-cell attracting factor, and it was an inverse correlation. So, and the TLS a priori is also associated with a good response to immunotherapy. So I think there's something there that we don't understand yet, and communication that we don't know yet, but there's something going on there between the B cells, maybe more immature B cells, more maybe higher levels, circulating levels of CXL13 means lower levels at the tumor level. I think there's something there that I can't respond. These were our results, but
because the hazard ratio is 0.7.
In the last one.
Yes, it was in the last slide, but
that's weird because the numeric, no, it wasn't like that.
okay, I understand.
I'm just going to check
Fine.
that was right,
Yeah, no
but a
problem.
priori they are all negative.
Okay,
Yes.
thank you. Yeah, Lisa.
Yes, I have a question for Dr. Verkar. So super interesting, and definitely what you're seeing pathologically matches what we see in the mouse kidney, which is super cool. You had a patient in whom the tumor led to the discovery of a germline TSC1 mutation, and I'm wondering if that patient subsequently had any other kidney manifestations. Did she have any tumors in the contralateral kidney or angiomyolipomas or any other features of TSC?
For our cohort or in general?
I'm talking about the patient in whom you discovered a germline mutation.
This was no. For this patient, that was a unique manifestation. For two other who had non-TSC, there is another manifestation such as other renal tumor, angiomyolipoma, or chromophobe, and extra-renal manifestation. So it was very surprising for this patient.
Okay, thank you. Please go ahead.
Okay, hi. I have a question for Ben. And I was wondering if you have any idea how it comes that when you're showing the comparison of which of the measures you presented, that patients would prefer to 26% the EQ5D, although they only found one of those domains to be relevant for them of 5. So it was somehow astonishing that this number was not so much different to the other ones. It was about 30% for the other ones, but still the EQ5D got such a quite good response. And I would be curious if you have any ideas about that.
I actually do have a little bit of insight into that. So a lot of the patients enjoyed the, I guess, spectra of answers on the EQ5D that they were able to select from, rather than kind of the binary, yes, I'm feeling this, no, I'm not feeling this. They appreciated the ability to have more answers, basically.
Okay, so beside only asking them what item is relevant, we should also focus a little bit on the way we give them possibilities to answer items, maybe?
Yeah, excellent suggestion. Thank you.
Thank you.
Just to continue with your presentation and your patients, how was the dropout of when you asked the patient to participate? Was there a dropout of the patient that didn't want to participate?
We had a fairly high participation rate. Most patients were willing to. Some obviously were rather busy and didn't have time, but it was received pretty positively.
Yeah. Was there a difference between the patients who underwent surgery and or had metastatic disease or what?
Not that we noticed, no.
Because that is a problem with if you want to build up a patient organization.
Mm-hmm.
Because the patients who had undergone surgery, they are feeling curable, and the metastatic patients, they often are tired and don't want to participate. You didn't have that in your setting?
We had a couple of metastatic patients that were actually curatively had surgery performed on them, and they were, of course, willing. But from what I noticed, we didn't really have a problem accruing metastatic patients on systemic therapy.
Okay, and another question is, how was the education level? Was that equal?
It was fairly balanced. I would say it was biased more towards more educated patients, but we had a fairly representative population, I'd say.
But I think we should push to get it more equal.
Yeah.
Thank you.
Dr. Hank?
Hi, it's Danny Hank from Calgary, Canada. Sorry, Ben, for putting you more on the spot. I loved that presentation, and I think developing a new contemporary quality of life score would be really exciting. And if you could keep it as short as possible, that would be great to reduce questionnaire burden. But if you had more patients with metastatic disease and more localized disease, what do you think the difference, if you made 2 separate questionnaires, would there be a difference? Would there be a need for 2 separate questionnaires for metastatic versus localized disease? And would there be any differences in some of the questions?
That is certainly something we could look into, and I believe from our preliminary results, which unfortunately don't have much statistical power to them, the questions would differ slightly, at least. And in terms of a kind of separate questionnaire, that may be warranted, and that is something I believe we should look into in our future trials.
Dr. Tanier?
Yeah, thank you. For a question for Dr. Atkins, accepting that the management of patients with favorable risk clear cell RCC is maybe controversial, and I was interested to see the data from the propensity score analysis between HCRN, GU216, and the Checkmate 214. What is your outside the context of a clinical trial, what would you treat a patient with favorable risk clear cell RCC? Because obviously the data from the PS analysis was driven mostly by the intermediate risk, poor risk. But for a favorable risk, would you treat with monotherapy anti-PD-1, combination of an IO-TKI, or Nivo-Ipi, outside the context of a clinical trial?
I would say stay tuned to the next session, where I will answer that for myself. But I do want to point out that it's a really area where that question needs some more data. And I feel that there's some problems with the Checkmate 214 favorable risk population, where there were a lot of early deaths that didn't happen in our HCN trial. As I showed this morning, we had only 1 death in 3 years in our favorable risk population, while there was somewhere in the range of 20 to 25% of patients in the Checkmate 214 trial who died at 3 years. And I'm curious to know what the difference in those 2 populations are. And that problem with the 214 trial, if it was the 214 trial that had problems, has really limited our options for what we can offer favorable risk patients currently.
Okay, thank you. That is all the time we have for questions. Thank you again for joining us in this session today.